Hi everyone, my name is Matt Galsky. I'm a medical oncologist at the Icahn School of Medicine at Mount Sinai in New York, where I focus on bladder cancer. Today we're going to be talking about high-risk non-muscle invasive bladder cancer and recent developments. The standard treatment for high-risk non-muscle invasive bladder cancer for decades has been BCG administered into the bladder. This is arguably one of the most effective cancer immunotherapies developed to date, but we know not all patients respond to BCG, and many patients receive BCG and subsequently develop disease recurrence. And so there's been an attempt over the years to improve upon BCG. We know from some translational studies performed several years ago that in specimens obtained from patients who develop recurrent non-muscle invasive bladder cancer after BCG exposure, that many of those samples demonstrate increased expression of PD-L1, and that in part has provided a basis for integrating immune checkpoint blockade with BCG as an upfront strategy. And there were 3 clinical trials designed around the same time addressing this very question: should we add immune checkpoint blockade to BCG? All of these studies were designed in similar ways with some nuances. So there was the POTOMAC study, which randomized patients between one of 3 arms: standard BCG induction and maintenance, BCG induction only plus durvalumab given once a month for 13 cycles, versus durvalumab versus BCG induction and maintenance with durvalumab. There was the Unmet study, which was designed in a similar way, which randomized patients to BCG or BCG with atezolizumab, and then the CREST study, which randomized patients to BCG or BCG with sasanlimab. Again, each of these studies addressing this issue of BCG with or without immune checkpoint blockade, with or without BCG induction and maintenance. The eligibility criteria for these studies were pretty similar. Patients were required to have high-risk non-muscle invasive bladder cancer that was BCG naive, and high risk was defined as having high-grade Ta disease, having T1 disease, and or having carcinoma in situ. Pretty standard definitions of high-risk non-muscle invasive bladder cancer. The primary endpoint of these studies were pretty similar, although they were defined slightly differently. Disease-free survival was the primary endpoint of the POTOMAC study. Event-free survival was the primary endpoint of the CREST study, although these were defined pretty similarly and included recurrence of high-grade disease or persistence of carcinoma in situ at 6 months or death. The POTOMAC study and the CREST study both met their primary endpoints, showing an improvement in disease-free survival or event-free survival, respectively, with a hazard ratio that was identical in both studies of 0.68. The Unmet study is the outlier. It didn't meet its primary endpoint, and it was the outlier also in terms of design of the study, only included a year of BCG maintenance, and the endpoint was defined as any grade recurrence, not recurrence of high-grade disease. So that was the outlier. The other 2 studies met their primary endpoints. Some differences between POTOMAC and CREST. In CREST, immune checkpoint blockade with durvalumab was administered for 13 cycles, as mentioned. In CREST, the sasanlimab, the PD-1 inhibitor, was given for 2 years of treatment. An important aspect of these trials, as mentioned, was that there was an arm that tested whether or not immune checkpoint blockade could substitute for maintenance BCG. And of course, one of the reasons for testing that strategy is because of the BCG shortages that have been experienced in recent years. Notably, in both POTOMAC and CREST, inadequate BCG could not be overcome with immune checkpoint blockade. That is, the benefit that was shown with the addition of immune checkpoint blockade to BCG was only seen when both BCG induction and maintenance was administered. On the basis of the POTOMAC study, the addition of durvalumab to BCG induction and maintenance is now approved by the US FDA and is a treatment strategy to consider for patients with high-risk non-muscle invasive bladder cancer that is BCG naive. Thank you for your attention today.